Hey everyone, we are going to discuss some clinical situations today, things you may run into in the emergency room or on the exams. The first one we're going to talk about is kind of a common site that we are called to in the emergency room. So the respiratory therapist is paged to the ER to assist in the management of a 68-year-old male. When the patient arrives to the ER, he's receiving a 10 centimeters of water mask CPAP with an FiO2 of 60% for respiratory distress that the paramedics have placed him on at the home. That is something that in the past they would just put a non-rebreather on the patient and bring them to the emergency room, but they do have some CPAP capability now in the field, so that's a great thing. He's had a history of CHF and he's been having some angina for the last few days. So we do our assessment. We see on the monitor his heart rate's 114, his respiratory rate's 34, so he's under some distress. His blood pressure is 158 over 114. His saturation's hovering around 89-90%, even on the CPAP. He has a pH of 7.27. His PCO2 is 56. His PO2 is 59. His bicarb is 25, and his base excess is -3. So what would we recommend as the RT in charge to help this patient? And how could we combat intubation? So let's not go straight to intubation just because the CPAP is not able to correct the issues. Remember, it's on a setting of 10 and our FiO2 is at 60%. So at this point, we want to go ahead and initiate non-invasive positive pressure ventilation. So we might pull in the Trilogy, or we may pull in some of the other machines we have in stock that are able to provide non-invasive positive pressure ventilation. We can do that by a full face mask, or we can do it with a nasal mask with a chin strap, but full face mask is usually recommended. So we want to set that NPPV on a significant pressure because we want to clear that pulmonary edema and CHF out of the alveoli. And we want to go ahead and recommend a diuretic as well, as long as the patient's not dehydrated already. And we want to try to stimulate the kidneys so they will diurese or urinate out that extra fluid overload. So we're going to go ahead and set up the IPAP at 18 and the EPAP at 10, which gives us that delta pressure of 8, and that can be referred to as well as the actual amount of pressure support. So that gap there will help improve gas exchange. It is more natural to have a patient on NPPV or BiPAP because we typically breathe out by increasing the eye pressure and then decreasing the pressure naturally. So we're not used to breathing out against a continuous pressure. And so that having that option of a more natural ventilatory flow will definitely help the patient. It'll be more comfortable and they'll be more likely to benefit from it. And you can see the pressure, the inspiratory pressure we're using is 18 and the expiratory pressure we're using is 10. So they are going to get quite a bit more ventilation, which is, we know ventilation is reflected on the ABG by looking at the PCO2 and the pH, primarily though the PCO2. And then that bumping that FiO2 to 70 is also going to help the hypoxemia that remains even on 60%. So let's bump him to 70, and that will hopefully push up that PO2 a little more and that saturation. So 2 hours later, we go back by and help transport the patient to ICU, get them all settled in, get them on the monitors, transport their NPPV over, and keep them on that. The heart rate then is 124, respiratory rate still 36 with accessory muscle use. The blood pressure is 154 over 102, so he's still hypertensive. The saturation is 93%, so that's improved a little bit. The pH is 7.19. Gee whiz, so now we've dropped even lower and we're more acidotic. The PCO2 is 64, so that PCO2 is climbing even with that NPPV. So the PO2 is 64 as well. The bicarb is 24 and the base excess is -5. So the body's trying to compensate, but it's just not able to bring the patient back into range on the pH and the rest of the blood gas. So the physician asked, well, RT on staff today, what do you think we should do? This patient's not getting any better. In fact, they're going the wrong direction, further into acidotic blood gas. So the RT would recommend intubation and mechanical ventilation at this point. The severe respiratory acidosis that is continuing to get worse needs immediate care, and so the team goes ahead and prepares to intubate the patient. So we need to gather suction. We need to have our oral Yonker suction and a suction catheters, adult size, about a 14, maybe some 12s. We need to have a clear suction bucket so we have plenty of room in the bucket, and because if your bucket becomes full, you will lose suction and you won't be able to clear the airway. You need to grab the laryngoscope. You need to have a curved blade with a Macintosh blade, or if the physician prefers, the Miller blade, which is a straight blade. We need to grab that ET tube, probably a size 8 would be good for this patient, as it's a male of average. He's 5'4" and weighs 130 pounds, so we could get by with a 7.5 maybe. So we're going to go ahead and get the patient intubated. If it doesn't work out well with the laryngoscope and we're unable to visualize the vocal cords, we can grab the glidoscope, pull it over, and get a camera visual on the screen and make that a lot easier to intubate. So once the patient's intubated, we want to secure the tube after we check and make sure that it is in the trachea. We're going to look for chest rise and fall, listen to breath sounds, make sure we have breath sounds on both sides. We're going to call x-ray on. They're probably waiting in the hall ready to take a chest x-ray so we can look and see if the tip of the ET tube is at 2 to 4 centimeters above the carina or 1 inch above the carina, and not down in the right main stem. If we do forward the ET tube too far during intubation, it is going to slide into the right main stem just because of the angle that the airway takes. The left is a little bit more less easy for the ET tube to slide into, so the ET tube is going to slide into that right main stem if it goes too far. So we're going to look and we're going to note where our ET tube is. Hopefully it's likely going to be around 21 at the lip, and we're going to secure that with the ET tube holder, inflate the cuff using the minimal leak technique, where we put in a full cuff and then listen with our stethoscope and back off till we hear just a very small leak. That way we're sure that we don't put too much pressure on the tracheal mucosa. And hopefully we'll get our chest x-ray. Our chest x-ray, a lot of the machines now have a screen on them, so you can hop over and take a look on that screen and see if if you can tell if the ET tube's in the right spot. And then the radiology folks will go back and actually print an x-ray, and it'll come up on the computer, either one. But a lot of the new machines have that where you can take at a glance, you can make sure you're in to the trachea. So you're going to secure the tube, listen to breath sounds, get your chest x-ray, place the patient on the ventilator. So what settings do we want to place the patient on? We're going to place them on at least 5 to 10 liters of minute ventilation, but we're going to try to use a tidal volume around 500 at the most, and then a rate around 12. We're going to use the FiO2 that they were already on, since they were on 70% on the NPPV. We're going to go ahead and continue using that. We're going to place them on 10 of PEEP, since they were already on 10 of EPAP. And then we are going to monitor the patient, get another blood gas a little later. Later in the day, the patient's still on the ventilator in volume control, assist control ventilation. The FiO2, you've went ahead and bumped it up to 75%. The rate is 12. Tidal volume remains around 500, and the PEEP remains at 10. Now the high pressure alarm is going off, it's activated, and you're at the bedside, and you need to evaluate what's going on. So the first thing that you're going to want to do is see if the patient needs suctioned. What's your peak pressure? If your peak pressure is increased, listen to breath sounds, go ahead and suction the airway and make sure that the ET tube is clear. That is the most common cause of a high pressure alarm. Make sure your patient's not been turned and might be laying on the tubing, and that would make it harder for the ventilator to deliver the breath. Also want to make sure that that the patient is not biting the tube. If they are and just chewing on it, then you're probably going to have to recommend some Versed or Valium to calm them down. So if you find that the ET tube is clear and you remove any sputum that might be in the airway, and then that corrects your alarm, then you know that increased airway resistance is what has caused the high pressure alarm to sound. If you suction the patient and they're still having high pressure alarm sounding and the peak pressure is still increased, then you want to see if there is a tracheal shift at all. There could be pneumothorax or atelectasis. At that point, you're going to have to call for a chest x-ray or a CT of the chest. The CT of the chest would be a bit overkill. You don't want to transport the patient to the CT lab at this point to have the test done. So you just go ahead and continue to monitor the patient. And if there is still high pressure alarms going off and you identify that there is a tracheal shift, then you can listen to breath sounds. If they are diminished, then you can go ahead and alert the team that you may need to place a chest tube in place or do a needle decompression. But hopefully just suctioning the patient will clear the airway and allow the high pressure alarms to stop sounding. And now you know the steps. If that doesn't work, then start evaluating for something bigger. But a lot of times it's just the high pressure because secretions are in the airway. You'd also want to check for bronchospasm. The patient may need a bronchodilator at that point. So you just got to continue to troubleshoot until you find the problem and the high pressure alarm is corrected. Never choose to instill normal saline to suction when you're taking the exam. That's never the correct answer. That's not recognized by the NBRC as safe practice, even though you may see it done in the clinical situation. And also never choose to increase the high pressure alarm setting. You don't want to just turn the setting up. You want to go ahead and find out what the problem is and correct that problem immediately. And so go through your steps, suction first, make sure the patient's not biting the tube or laying on the tube, and then if it continues, go ahead and listen to breath sounds and see if there's a tracheal shift, and if there is, then you would want to get a chest x-ray and see if you need to do a needle decompression or a chest tube. And then it could also be bronchospasm, so see if you need to give an extra bronchodilator and when they had their last one. Okay, so that's kind of walking through the steps of working with a patient that's going into respiratory failure and has some fluid overload and needs, we tried to keep him off the ventilator but was unsuccessful, so we had to go ahead and intubate. So you'll see that scenario on boards, and you'll also walk through that scenario in the clinical setting several times in your career. So you'll be prepared and you'll